All right, welcome back. So today we're going to talk about why two patients can take the same psychiatric medication at the same dose and have completely different outcomes. One gets better, the other gets side effects or no benefit at all. Psychiatry has historically relied on trial and error, and we start a medication, we wait a few weeks, we adjust it, we switch, we add, we subtract, and hope we land in the right place. Now, what this lecture is about is moving beyond guessing. We're going to talk about Therapeutic Drug Monitoring, also called TDM, and Pharmacogenetics. This will give us tools to understand why medications behave differently in different bodies. Not just whether a drug works, but how much drug actually reaches the brain, how fast it gets cleared, and whether the patient's genes change that process. The goal here is to be as precise as possible with something as imprecise as psychiatry. We're not looking at perfect prediction, but we want better explanations and safer decisions. So think of this like two people drink the same amount of alcohol. One is relaxed and the other one is vomiting or blacked out. Same dose, different biology. Well, psychiatry is no different. So by the end of this session, you should be able to explain medication variability using pharmacokinetics, drug levels, and genetic differences, rather than just saying patients respond differently. So this is how we're going to move from population averages to the patient sitting in front of us. Now, in our last lecture, we talked about mediators versus moderators. And a simple way to remember this is that mediators explain why and how something works, whereas moderators explain for whom it works and under what conditions. So, for example, serotonin reuptake inhibition is a mediator. That's the mechanism how SSRIs exert their effect. But age, sex, body composition, liver function, drug interactions, genetics, those were all moderators. Now, they don't cause the effect. They change how strong, weak, fast, or dangerous that effect becomes. And this is where genotypes come in. Genes are not mediators. Your genes do not treat depression. They don't cure anxiety. They don't do the work. Instead, genotypes act as moderators, and they shape how your body handles a drug, how fast it's metabolized, how high the blood levels get, how long it sticks around. Think of it like this. The medication is the car. The mechanism is the engine. But the genotype is the road conditions. Same car, same engine, but ice, rain, traffic, potholes completely change how the ride goes. And that's why two patients can both be on fluoxetine 20. One feels nothing, one feels agitated and nauseous, one feels great. Same drug, same dose, different moderators. Okay, so today's focus is on how pharmacokinetics, what the body does to the drug, combined with genetics, explains that variability in a way that's predictable and testable and clinically useful. This is going to be the shift from population-based prescribing to individual prescribing, not guessing better, but understanding more. So as we go through this lecture, I want you to keep asking yourself, what patient factors is moderating this drug's effect right now? That's the mindset that separates a protocol following from clinical reasoning. So the core question today, we're going to keep coming back to this, is why do two patients on the same medication at the same dose have completely different outcomes? One improves, one gets worse, one has side effects. So if you don't have a framework for answering this question, everything in prescribing starts to feel random. So and then things start to feel random, and then clinicians overreact and freeze. The answer is not because psychiatry is subjective, but the answer is really because biology is variable. And we can break that variability into three big drivers: pharmacokinetic drivers, genetic drivers, and clinical factors. Now first, pharmacokinetic factors is responsible for what we call ADME, absorption, distribution, metabolism, and excretion. This is simply what the body does to the drug. The same thing happens with psychotropics like sertraline, risperidone, lithium, and illicit drugs like cocaine, heroin, etc. All of those follow ADME principles. So if someone absorbs a drug poorly, it never reaches therapeutic level. And if they distribute it differently, say more into fat tissue, it may act slower or longer. If they metabolize it quickly, levels drop. If they excrete it slowly, levels build up and can cause toxicity. Same pill, same substance, very different internal exposure. Now, the second factor that plays into this question is genetics. Now, genetics sit right on top of this ADME, especially as it relates to metabolism. The CYP enzyme, like CYP2D6, CYP2C19, CYP1A2, they act like metabolic speed dials. Some people metabolize drugs slowly. Some metabolize at an average rate, and some metabolize extremely fast. So a poor metabolizer on, say, nortriptyline may get anticholinergic toxicity at a normal dose. But an ultra-rapid metabolizer, say on fluoxetine, might feel nothing at all. There's also HLA variants that matter too. They don't just change the drug level, but they change immune reactions to the drug. So that's why something like carbamazepine can feel safe for one patient and dangerous for another. Another factor with respect to genetics is MTHFR, and this comes up a lot, and we'll talk about it and what it does and where it does not matter and where it might matter. But the key point is that genes don't just choose the drug, they change how risky or effective the drug becomes. And the third issue is clinical factors, and this is the part that clinicians will often underestimate. So drug-drug interactions, liver or kidney disease, smoking concurrently, obesity, adherence. Patients on clozapine who smoke will metabolize it faster. And then if they stop smoking, say in the hospital, suddenly the clozapine level will spike without changing the dose. So a patient who misses doses may look like a non-responder, when the real issue is exposure, not efficacy. So these factors don't show up neatly in trials, but they do dominate real-world outcomes. So when you see different outcomes, don't ask, is the drug good or bad? Ask instead, how is the patient handling this drug? So today's roadmap of therapeutic drug monitoring fundamentals, we're going to measure exposure, and we'll look at pharmacokinetic models and kinetics of drugs and how levels rise and fall. And we'll also talk about pharmacogenetics, where we will integrate the genes without overusing them. And by the end of the lecture, the goal is that you not memorize enzymes, but that you stop being surprised by variability and start to expect it. All right, so this is the slide where the rest of our thinking about therapeutic drug monitoring actually is. And just importantly, we're going to learn what it is and what it is not. At its simplest, therapeutic drug monitoring means measuring how much drug is actually in the blood. Not how much was prescribed and not how much the patient thinks or tells you that they're taking, but how much drug is circulating in the system. So we do this to balance two competing goals. We need enough drug in the system so that it works, but not so much that it causes harm. So why does this matter, especially in psychiatry? Because many of our drugs have therapeutic windows. I mean, it means the difference between helpful and harmful. And that difference is surprisingly small, especially when you think about drugs like lithium or valproic acid or clozapine. You can have two patients on the same dose, and one person is stable and the other is tremulous and sedated and confused and toxic. So the main thing I need you to take home from this lecture is that you have to remember to treat the patient, not just the number. A lab value, after all, does not treat depression. A lab value does not cause side effects. The drug that the patient is in the system, that's what causes the problem. So you can have a therapeutic lithium level and still see toxicity with tremor and nausea and confusion, especially in older adults or those that may have kidney disease. And you can even have a level that's technically low, but the patient feels better, functions better, has no side effects. So the number really only makes sense when it matches the clinical picture. So think of it like checking the speedometer on the car, right? It'll tell you how fast you're going, but it doesn't tell you whether whether the road is icy, whether its visibility is poor or the brakes are worn, right? So drug levels are like the speedometer, but the patient, that's the road. And if you ignore the patient because the number looks fine, well, that's how people get hurt. This is why we can't have nice things, okay? So 3 real purposes for therapeutic drug monitoring in real life, okay? Efficacy, number 1. So if the patient is not improving, a level helps answer the question, is the dose too low or is this just the wrong drug? So for example, a patient on valproate acid for mood stabilization who isn't responding. Before you add another medication, you should know whether there's even a therapeutic range. Right? The other thing is safety. So some side effects don't show up gradually, they show up all at once. For example, like clozapine and seizures, or lithium toxicity after dehydration, or valproic acid's hyperammonemia. The therapeutic drug monitoring helps you catch that risk before the patient winds up in the emergency room. And the third reason we do this is because we want to check adherence, right? Sometimes what looks like treatment resistance is actually non-adherence. So yes, I trust the patient, but I need to verify. For example, they could be doing their own irregular dosing or taking something out causing a drug interaction. And that drug level quietly can answer the question, is the medication not working or is it not being taken? Now this slide is about judgment, not just reflexes. Therapeutic drug monitoring is a powerful tool to have, but it's not harmless, it's not free, it's not neutral. Every lab you order needs to answer a real clinical question. So take a look at the left side here. Now when should you order? Well, drugs with narrow therapeutic index, first you order levels when the drug has that narrow therapeutic index, like lithium or clozapine is another. Now with these drugs, the line between effective and toxic is very thin. So a small change in kidney function, hydration status, suddenly start smoking, or a drug interaction can push this patient into the danger zone. So if the margin of safety is small, guessing is not acceptable, order. The other thing, another time to order a therapeutic drug level would be if you have new or worsening symptoms, that is of toxicity. So if there's a change, so if a patient on lithium develops a tremor, nausea, diarrhea, confusion, that's not anxiety until you rule out toxicity. Also, if a patient on clozapine becomes excessively sedated or has a seizure, you don't debate the diagnosis first, you check the drug level. Symptoms come first, labs explain them, so we don't use them as a fishing expedition. The other thing to check is if you suspect interactions are non-adherent. So that would be another time to do it. So if the drug is not effective or you think it's not working, or maybe it's not even present, that's a time to check. And if you're in a special populations for all intent and purposes means children, the elderly, and the pregnant, okay? That's another time to check it because those factors of life affect renal and hepatic function. So a lithium dose that was fine at age 35 could be dangerous as that person turns 75. So when physiology changes, the level matters more. Now, take a look at the right side of the screen here. When should you hold off or not order? Well, if the patient is stable and asymptomatic. Now, this is where restraint matters. If the patient is stable, functioning, asymptomatic, a level can add you more anxiety without benefit. So you don't just check just to check. That's how you end up chasing numbers instead of treating people. Also, you don't check if the result is not going to change the management. And this is the most important rule. If the results are not going to change what you're going to do, don't order it. Also, if you already know you're going to continue that same dose or taper it regardless of the level, or you're just going to monitor them clinically, then the lab is just adding noise, so you don't need to check it then either. The other thing, of course, is cost, right? Cost has to outweigh benefit. Many of these labs are expensive, so if the patient is uninsured, underinsured, ordering a level without a clear purpose can cause real harm. So good medicine has to include financial realism. Oh, this is a big one too. So pay attention to this especially. Too soon after a dose change. Timing in therapeutic drug levels matter. So if you order a level before they hit steady state, the number is basically meaningless. And how long is steady state? 5 to 6 half-lives. That's how long you need to let the drug be in the system before you check the lithium. Not 2 days after you start a dose, because that tells you nothing. You started too soon. So stop and think. This question should run in your head every time you consider doing this. Will this level change what I do today? If the answer is no, pause, because thoughtful restraint is just as important as good action. So this slide looks simple, but it's one of the most dangerous slides in psychopharmacology if you misunderstand it. These numbers are guides, not guarantees. So a therapeutic range is not a safety bubble. It does not mean that below this does not work, and it does not mean that above this is always toxic. What it means is most people tend to respond somewhere in this range, and individuals live outside averages. So look at lithium, 0.6 to 1.2 milliequivalents per liter, up to 1.5 in acute mania. So lithium is the textbook example of why levels matter. The difference between helpful and harmful is quite small, and you always draw this level 12 hours after the dose is in, not randomly. That means you take the dose, wait 12 hours, and then draw. In the outpatient setting, you want to find out from the patient what time of day they usually take the medication, and then draw it. A level drawn too early looks falsely high. A level drawn too late looks falsely low. So remember, elderly patients, dehydration, NSAIDs, ACE inhibitors, kidney disease can all turn a normal dose right into toxicity. The other thing is look for signs that match the clinical picture: tremor, nausea, diarrhea, confusion. Those are lithium symptoms until proven otherwise. Valproic acid, divalproics, total level 50 to 100, free level 6 to 22. Now valproate is sneaky. Most labs report total valproate. But the brain only cares about free drug. So if albumin is low in an elderly or a malnourished patient, or they have liver disease, then the free level can be toxic when the total level looks normal. So that's how the patients will look like they're sedated or have ataxia or confusion, even at a therapeutic level. So in acute mania, levels may be pushed higher, but that is a deliberate and closely monitored choice. Carbamazepine. The range is from 4 to 12 micrograms per milliliter. Carbamazepine is special because at certain levels it starts to induce its own metabolism. So that means you increase the dose, the level rises, and then drops again over 1 to 2 weeks. So if you don't recheck levels after a dose change, you'll think the drug has stopped working, when really the liver just picked up the pace and started burning up the drug. So that's a classic prescribing trap. Clozapine, on the other hand, 350 to 600 nanograms per milliliter. Clozapine levels correlate better with response than most psychotropics. So below 350, many patients don't respond. And above 600, seizure risk rises fast. So also smoking matters here. So if a patient stops smoking, clozapine levels can double without any dose change. So that's how stable patients suddenly seize. So remember, you're treating the patient, not the number, and a patient can be toxic inside the therapeutic range. A patient can be well outside the therapeutic range. So numbers are used to explain symptoms, but they never replace them. So a perfectly ordered lab drawn at the wrong time is basically useless because it's very misleading. Drug levels rise and fall over the course of the day. So if you don't standardize the timing of the draw and the administration, you're comparing apples to oranges. So that's how you get clinicians panicking over toxic levels that are not toxic and miss real problems that are real. Lithium is your non-negotiable. You have to draw this at 12-hour trough, not 10. Sometime in the morning, not after the patient just took the dose, because lithium peaks early. A level drawn at 2 hours after a dose can look dangerously high, even in a perfectly stable patient. That's not toxicity, that's just bad timing. The other thing is this happens all the time in hospitals. The nurse will draw labs at 8 a.m., the patient took the lithium at 6 a.m., and now you have this falsely elevated level, and suddenly everyone's talking about stopping lithium. That's a lab error, not a clinical emergency. Valproate is more forgiving, but timing still matters. You want to get a trough level drawn just before the next dose. So if albumin is low, elderly patients, renal impairment, liver disease, malnutrition, you need to check the free valproate level. Otherwise, the patient can be toxic even when the total levels look normal. So that's how patients end up sedated, unsteady, confused. Even with therapeutic labs, they can fall on the floor. Carbamazepine adds another twist because it does induce its own metabolism through the CYP3A4 pathway. Early on, the level can look fine, and then it drops weeks later without any dosage changes. So that's why you need to recheck these levels 1 to 2 weeks after a dose change. If you don't, you're likely to think the drug failed when the liver just picked up the pace. And clozapine levels are not just about toxicity because they answer two big questions. Is the patient absorbing the drug, number one? And number two, is the dose high enough to work? Because low levels can mean either non-adherence, they've started smoking or smoking more, or rapid metabolism. That's not treatment failure. And high levels raise the seizure risk, but again, timing and context matters a lot. So this is one of the most common therapeutic drug monitoring errors. Drawing the lithium level 2 hours after the dose instead of at the trough creates this false alarm, right? The problem's not the drug, it's the clock. So before anyone sticks the needle in, ask the question, did you take your morning meds yet? Because that single sentence is going to prevent more medication errors than most guidelines. Now, everything we do in prescribing comes back to this one simple question. What happens to the drug after it enters the body? That entire journey is captured by this ADME. If you understand ADME, absorption, distribution, metabolism, excretion, you understand why two patients on the same dose can have a completely different outcome. So absorption is just this. It's how does the drug get from where you put it into the bloodstream. So if the drug never gets into the bloodstream, nothing else matters. So think about things like SSRIs, immediate release sertraline. It hits faster than the extended release formulation drugs, right? Food, stomach acid, gut motility. Now that everyone's on a GLP-1, what is that doing to absorption? All of that affects how much drug actually makes it in. So this is also where adherence hides. So if the patient isn't taking the medication, absorption is zero, no matter how perfect your prescription was, right? The other thing to think about is this is why smoking cocaine hits a lot faster than swallowing the cocaine, right? Same drug, different absorption, very different clinical effect. Distribution. Once the drug hits the blood, the next question is where does it go? Distribution is movement from blood into tissue, especially the brain in our case. So where does it go? Distribution is movement from blood into tissue, and so protein binding matters a lot here. Drugs that bind tightly to albumin, like valproate, can look normal on labs but still cause toxicity if the albumin is low. Fat also matters. Highly lipophilic drugs, like many antipsychotics, hide in fat and slowly leak back into circulation. That's why obese patients sometimes will respond differently, even at standard doses. This is also why two patients with the same blood level can feel very different. One has a drug where it matters, in the brain. The other does not. Now, metabolism, this is where most surprises happen. So metabolism is how the liver chemically changes the drug, mainly through the CYP enzyme system. So phase 1 is the oxidation phase. That's mostly CYP450's claim to fame. Phase 2 is the conjugation. That's making drugs easier to extract. So genetics matter here. So if you're a CYP2D6 poor metabolizer, you're going to accumulate drugs like risperidone and venlafaxine faster, right? But if you are an ultra rapid metabolizer, you may look treatment resistant when the drug is really just flying through your system too fast. Now, the other thing to keep in mind, this is why some people can drink all night long and others get drunk fast. Same alcohol, different metabolic rate. Now the E is for excretion, and excretion is how the drug or its metabolites leave the body. Now mostly that happens through the kidneys. If renal function drops off, drug levels rise, even if the dose was never changed. So think about the things that can impair renal function. Lithium is the classic trap here, right? Reduced glomerular filtration equals lithium accumulation. That's not non-compliance, that's physiology. So in your most complex outpatients, which ADME step actually varies the most? It's usually not absorption. It's metabolism and excretion, because things like age, genetics, organ function, and drug interactions stack up over time. So ADME, pharmacokinetics, explains the variability. It explains why the guidelines are failing at the bedsides and why therapeutic drug monitoring exists in the first place. Now, this is such an important concept, it's made it into pop movies. So check out the movie Cockblockers for an example of where this plays out. But this slide explains one of the most common reasons a medication doesn't work the way you expect, even when the dose looks reasonable. So the key idea here is something called first pass effect. Now look at the left side of the screen. So the mechanism, when a patient swallows a pill, it does not go straight into the bloodstream. First, it goes through the stomach and the intestines. Then, and this is the crucial step here, it goes straight to the liver through the portal vein. The liver acts like a security checkpoint. A large portion of the drug can be broken down before it ever reaches the rest of the body. And that loss is called the first pass effect. This practical result is reducing bioavailability, meaning less active drug will actually see the brain. So this is why something like propranolol needs much higher oral doses compared to IV. The liver extracts so much of it on the first pass that only a fraction survives. Same drug, different route, very different effect, right? So bioavailability just means what percentage of the drug actually makes it into circulation in active form. If bioavailability is low, then you need a higher oral dose to get the same effect. If bioavailability suddenly increases, then the side effects appear fast. So many psych meds are taken orally, so first pass metabolism matters a lot in psychiatry. Two patients on the same SSRI dose can have a very different blood level, not because one is non-compliant, but because their liver handles the drug differently. Now on the right side of the screen here, you'll see genetics as a moderator. Now this is where genetics plays a big factor, because they don't cause the drug effect. They moderate it. They change how strong or how weak the first pass effect is. So the CYP enzyme in the liver determines how aggressively a drug is metabolized. Some people are slow metabolizers, others are fast metabolizers. Neither is normal or abnormal, they're just different. Now here's a concept that may be new, but hopefully not, because you've all had general pharm. Some medications are pro-drugs. That means they are inactive when swallowed. They require first pass metabolism to be converted into active drug. If that conversion doesn't happen, the medication will fail even at the right dose. Another example is a drug called clopidogrel, Plavix. This is a classic example. Patients with a CYP2C19 poor metabolizer status can take it perfectly and still get no benefit. That's not non-adherence, that's just the genetics moderating the first pass activation. So think of something like alcohol. Some people feel the effects quickly with one drink. Others need several drinks. That's the difference that starts in the liver before the alcohol ever reaches the brain. So first pass metabolism explains why oral dosing is not predictable. Pharmacogenetics explains why standard doses don't always work for everybody, and this is why pharmacogenetics and therapeutic drug monitoring exist, not to replace your clinical judgment, but to support it. You'll see in the movie that I mentioned earlier how they try to consume alcohol by another means, not oral, as a way of getting drunk faster in the movie. So once you understand first-pass metabolism, the next logical question is what happens when the liver gets overwhelmed? And that's where we're going to talk about order of kinetics and why some drugs behave linearly while others do not. Well, what are some ways we can bypass first-pass effect? If the liver is the checkpoint that reduces drug exposure, then the obvious next question is what happens when we go around that checkpoint? So some routes of administration send the drug straight into systemic circulation. That means little to no first-pass metabolism. So the same medication at the same milligram dose can feel much stronger just by changing the route of administration. Sublingual or buccal, this medication dissolves under the tongue or in the cheek. It's absorbed directly into the blood vessels and that drain into the superior vena cava, and that means it reaches the brain before the liver ever gets a chance to break it down. Right? So acenapine, classic psych example, right? If swallowed, largely destroyed by first-pass metabolism. So that's why patients are told very clearly, do not swallow this. Same drug, same dose, completely different exposure. Parenteral routes also bypass the GI tract entirely, so IV administration has 100% bioavailability. There's no first pass, there's no guesswork. This is why IV drugs feel immediate and intense. So this is also why IV substances, whether medications or illicits, carry a much higher risk of overdose. There's nothing to slow it down. Inhaled drugs are also absorbed through the lungs. Transdermal drugs absorbed through skin capillaries. Both routes enter systemic circulation before the liver sees them. So inhalation works rapidly because it behaves more like IV than a pill. Selegiline is a patch that avoids the gut and liver metabolism, changing both side effect profile and drug interaction. Same molecule, different route, different pharmacology. Rectal, this is variable. Rectal administration is unpredictable. The lower rectum bypasses the liver. The upper rectum drains into the portal system and does not bypass the liver. So part of this variability is why rectal dosing is hard to standardize. Again, I refer you to the movie. Now, the route choice can be as powerful as a dose choice. So changing from oral to sublingual, inhaled, or transdermal, it isn't just about convenience. You are fundamentally changing how much drug the brain sees and how fast. Now, you might have to do that if you're going to court for treatment over objection. Now, there are some clinical consequences. So a patient can suddenly develop side effects simply after a route change. And it also explains why some patients fail oral meds but respond beautifully to patch or sublingual formulation. That's not placebo or non-adherence, that's the pharmacokinetics. So now we've seen how route can change exposure. The next step is understanding what happens when metabolic systems get saturated. So that's when we'll talk about order of kinetics and where small dose changes can suddenly become dangerous. All right, now we're going to talk about how most medications behave at normal doses. So if you remember nothing else, remember this phrase. Linear or first order equals predictable. Okay, so first order kinetics means that this constant percentage of the drug percentage is eliminated over time, not a constant amount, a constant fraction. So the body scales elimination based on how much drug is present. More drug in the system means more drug is cleared per hour, but in the same proportion. That's linear first order. So think of this like draining a bathtub. If the drain removes 10% of the water every minute, A full tub loses a lot of water. A half full tub loses less, but the percentage is the same. That's first order kinetics. So most SSRIs behave this way, sertraline, fluoxetine. Most antipsychotics do as well within therapeutic ranges. Most benzodiazepines also follow first order kinetics at usual doses. So this is why we can titrate these medications safely. Now, why does this matter clinically? Well, because the relationship is linear, dose changes will behave as you expect. Now, if you double the dose, you roughly double the serum concentration. That doesn't mean you double the effect, but you do double the exposure. So that predictability is what makes outpatient psychopharmacology possible. Now let's look at the example on the slide. If sertraline 50 milligrams isn't effective, what happens if you increase to 100? Well, you can reasonably expect about double the serum concentration. No surprise, right? No nonlinear jumps, no sudden toxicity, assuming normal metabolism. Well, because of this predictability, we don't routinely check blood levels of SSRIs. And when we do check, it's usually for questions, not safety. Questions like, are they taking it? Is there a drug interaction? Is absorption impaired? Not because we're worried about drugs suddenly becoming toxic. So this linear behavior only holds until metabolic systems become saturated. And when saturation happens, these rules change. So that's when dose increases stop being predictable. That's when therapeutic drug monitoring becomes much more critical. So remember, first order kinetics, predictable, proportional, forgiving. The next slide is where things are going to get dangerous. That zero order kinetics, where small order doses can cause big jumps in blood levels. All right, so this is where it gets to be less forgiving. Abandon all hope while you enter here. Everything we just said about predictability no longer applies. Okay, so start with this definition here. Zero order kinetics means the body can only eliminate a fixed amount of drug per unit per time. A fixed amount of drug per unit per time, not a percentage. A fixed amount. So for example, the liver can only clear 10 milligrams per hour, whatever drug. No matter how much drug is in the body, it can only clear 10 milligrams per hour. So imagine a one-lane tunnel. Only 10 cars can exit per hour. If 10 cars arrive, no problem. If 50 cars arrive, the extra cars don't disappear, they pile up. That pile up, that's toxicity. So, why this happens biologically is metabolic enzymes become saturated. The system hits maximum capacity. So once the enzymes are working as fast as they possibly can, adding more drug does nothing to speed up the elimination. The excess has nowhere to go, so the blood level rises sharply. So the classic example here is alcohol, ethanol, right? It's the easiest example because everyone has seen it. So your liver can metabolize about one standard drink per hour, 35 to 40 per hour. Now, if you drink faster than that, alcohol accumulates. That's why the third or fourth drink doesn't feel linear. And that's why small increases in intake can suddenly cause a blackout or poisoning. Phenytoin is a classic example. A tiny increase, say from 300 to 400, can suddenly push the patient from therapeutic to toxic. And all of a sudden they have ataxia, nystagmus, confusion, all out of nowhere, no warning symptoms whatsoever. Well, in psychiatry, clozapine is not purely zero order, but it behaves functionally like this at higher concentration. So once the metabolism is saturated or inhibited, levels can rise much faster than expected. So that's why clozapine requires blood level monitoring. So here's the sentence I want burned into your brain. In zero-order kinetics, doubling the dose does not double the blood level. It might even triple it. So, and toxicity can appear suddenly, even if the patient was stable last week. So this is why the red box exists. The danger isn't that clinicians don't know the rules. The danger is that clinicians assume linear behavior when it no longer applies. And that's the assumption is how patients get hurt. So compare the two slides in your mind. First order, predictable, proportional, forgiving. Zero order, nonlinear, disproportionate danger. So this is exactly why therapeutic drug monitoring exists. When the kinetics are nonlinear, you can't rely on your intuition. You have to measure the levels. And the number matters because biology has stopped behaving politely, okay? So now, here's the key thing to keep in mind. Most drugs are first order until they're not. And then genetics and drug interactions and liver disease and dose escalation can push the drug from linear into nonlinear territory, and that's where pharmacogenetics then enters the conversation. But wait, there's more. So this slide explains why patients sometimes get worse after you think the drug should be gone, and why withdrawal and toxicity don't always follow the clock you expect. So far we've talked about the two extremes. First order, predictable, proportional, and zero order, danger zone once the enzymes are saturated. Well, this slide sits in between. We have curvilinear and logarithmic kinetics. They explain the reasons of delayed toxicity, delayed withdrawal, and long-lasting effects. So curvilinear kinetics means the drug starts behaving linearly, but as the dose rises or conditions change, it begins to behave like zero-order kinetics. So in other words, what used to be predictable suddenly is not. Lithium is a good example here of curvilinear drugs. At first, the dose increase behaves normally, but then something small happens. The patient gets dehydrated, they take an extra Advil, their kidney function dips slightly, and suddenly lithium levels spike up dramatically. Not because the dose changed, and not because you got the timing wrong, but because elimination capacity has changed. That's the curvilinear kinetics. So patients can be stable for years until a minor physiologic insult occurs, and then it pushes them over the edge. Logarithmic kinetics, this is sneaky, because it gives you a false sense of resolution. So logarithmic means that the drug leaves the body quickly at first, but then lingers in the tissue, especially the fat, and clears very slowly over time. This creates what you call a long tail. So a long tail means delayed consequences. A low blood level does not mean the drug is gone. It just means it's no longer floating in the bloodstream. So a drug that's good like this is something like diazepam, highly lipophilic. It redistributes into fat and muscle, and sedation may fade in days. But withdrawal can then show up weeks later. That's why benzo tapers have to be slow, even when the levels look low. THC, marijuana, practically everywhere in the air and in the salad greens and in the edibles and the brownies. THC is another perfect example. It disappears from plasma quickly. I'm fine. I feel fine. But it's stored in the fat. And that's why mood changes, anxiety, sleep disruption, paranoia, hallucinations can emerge long after someone stops using. It's in the fat. It's just being constantly released slowly. Fluoxetine behaves similarly, though less dramatically. It has a long half-life to begin with and active metabolites. So what that means is withdrawal is delayed, but it happens more slowly, so you may not observe too many symptoms. The problem is it's still on board, so drug interactions can persist weeks after stopping it. So you think you're putting it in a clean system, but you're not, and you could be having a drug-drug interaction. The Prozac you stopped last week, and this week you're on an oxycodone or OxyContin for some acute pain situation, and you set the stage for serotonin syndrome. So a side effect can outlast the prescription. So let's compare now. We have zero order, rapid, dangerous spikes. Curvilinear, sudden instability after a trigger. Logarithmic, slow, delayed fallout. Different curves, different clinical mistakes. So this is why timing matters as much as dose. This is why you can't rely on a single blood level. And this is why patients say, I stopped the medication weeks ago. Why do I still feel this? So now that you've seen how drugs behave across different curves, the next question is kind of obvious. Well, what determines where a patient lands on that curve? Well, that's where pharmacogenetics and drug interactions become a factor. So this slide explains why more gabapentin doesn't reliably mean more effect, and why patients on very high doses can sometimes look unchanged. Start with the shape. No math. Gabapentin follows something called sigmoidal kinetics. That just means the response curve looks like an S. So it's slow at first, then useful, and then it flattens out. At a certain point, the system maxes out. So gabapentin does not diffuse freely across the gut. It depends on a carrier system, an L-amino acid transporter in the GI tract. Now that transporter has a limit. Once it's full, extra drug just passes right on through. It doesn't get absorbed. So unlike most psych meds, gabapentin absorption is what you call saturable, and the gut becomes the bottleneck. So let me just walk you through the bioavailability. So let's look at these numbers carefully. At 900 milligrams per day, about 60% is absorbed. At 1200 milligrams a day, absorption drops to about 47%. At 2400 milligrams a day, only about a third is absorbed. And by 3600 milligrams, you're barely gaining anything extra beyond that. And then returns are basically minimal. So if we translate that, if you double the dose, you're not really doubling the blood level. In fact, you may barely bump it up at all. So that's why patients can be on huge doses and still say, I don't feel a difference. So that's why a good dosing strategy matters. Gabapentin works better if you divide the dose. You want to give smaller amounts spread out. You want to give the transporter time to reset. 3 or 4 doses per day beats 1 or 2 larger doses. And this is the pharmacokinetic issue, not non-compliance, okay? So a common reflex is, it's not working, let's just increase it. Now with gabapentin, that instinct is going to fail you, because at high doses, you're just feeding the toilet, essentially. So think of it like a subway turnstile. Only so many people can get through per minute, right? Once the line is backed up, pushing harder is not going to move through. It just creates congestion. So this matters for anxiety and sleep and pain and withdrawal support, especially in patients with substance use histories. You may see sedation without efficacy or side effects without benefit. If you compare this to an SSRI or most antipsychotics, those behave predictably. More dose, more level, gabapentin breaks the rule. So gabapentin teaches us a real important lesson. Dose is not the same as exposure, and pharmacokinetics can quietly defeat the good intentions. Let's talk about these two common drugs, often treated as interchangeably. They're related, but they're not the same in practice. And confusing them is a common cause of side effects and non-adherence and unnecessary discontinuation. So this slide is really about formulation, not chemistry, right? Same active molecule, different delivery experience. So let's start with valproic acid IR, often called depokine. And this is the immediate release form. It's a simple carbolic acid. That means it's absorbed quickly. But it's also quite harsh on the GI tract. So this is why patients will often complain of nausea and reflux and abdominal pain. Liquids and IR capsules will hit first and fast. So fast absorption means higher peaks, and higher peaks mean more tremor, more sedation, more GI upset, especially early on in treatment. Divalproex, known as Depokate, Depakote rather, is a coordinated compound. So valproic acid plus sodium valproate. Now this stabilizes the molecule and smooths out the absorption. The main advantage here is tolerability. Now, delayed release means it dissolves later in the gut. Extended release means the drug comes out slowly over time. Both reduce the sharp peaks. Neither changes the drug's identity, just its behavior. So think of this like caffeine. If you chug an espresso versus sipping coffee over hours. Same stimulant, different experience, right? So this is why the extend release, delayed release formulations are preferred for chronic management and mood stabilization and seizure prevention, because long-term behavioral control is the goal. You want smoother blood levels, fewer side effects, better adherence. So a common prescriber error is that the patient fails valproic acid IR. So what do they conclude? Well, valproate doesn't work for them. But often the real issue is the formulation intolerance, not the inefficacy. So this also matters when you interpret drug levels. IR formulations produce peaks and troughs that look unstable. ER formulations will produce a flatter curve. Same number on the lab slip, different lived experience. So when you're choosing between these two, you need to ask yourself, is this for short-term stabilization or long-term therapy? If it's going to be long-term, the smoother will always win. So valproic acid and divalproics are chemically related, but the clinical formulation is the intervention, and tolerability determines whether the drug ever gets a chance to work. Now, this is one of the most dangerous lab misunderstandings in psychopharmacology. A normal total valproate level does not guarantee safety because only the free drug is active. So valproate is highly protein bound. About 80 to 90% is stuck onto the albumin. Only the unbound fraction crosses the blood-brain barrier and gives us the desired effects. So if the total level is what we usually order, it measures bound plus unbound of the drug. That typical target is 50 to 100. In mania, we might push that up to 125, and that works only if albumin is normal. So total levels assume that the patient has normal protein binding. Now, if the albumin is low, the math breaks down. So the number looks fine, but the brain is really overdosed. So the free level measures what actually matters. This is the pharmacologically active drug, and usually that's between 6 to 22 micrograms per milliliter. So when albumin drops, fewer parking spots are available, right? More valproate floats freely, and that means more drug enters the brain without changing the total number. So think of albumin like buses, right? If there are fewer buses, more people walk. And walkers get places faster. So you must think about a free level when 1 liver disease or malnutrition or 2 renal failure or uremia or 3 drug displacement like aspirin pushing valproate off the albumin. So like an older adult on valproate becomes confused and ataxic, and the total level comes back 85. Now everyone relax, but the patient is toxic. The problem wasn't the dose, it was the protein binding. So if a patient has toxicity symptoms with a normal total level, that's not meant to reassure you, that's a red flag. Check the free level immediately. So this is where pharmacokinetics meets real life. You always need to keep in mind things like hydration status, nutrition status, age, comorbid illness. All of that matters more than the dose. So total levels are fine for routine monitoring, but free levels are for the unexplained toxicity profile, right? And when they disagree, you need to believe the patient, not the total number. All right, so let's talk about one of the most important valproic complications that you need to recognize, because this can happen at perfectly therapeutic levels and because labs can look reassuring while the brain is failing. So valproate can raise ammonia. That ammonia can poison the brain, and it can do it without obvious liver failure. So many clinicians assume elevated ammonia means severe liver disease, and that's not true here. Liver function tests can be near normal. The problem here is metabolic, not hepatocellular necrosis. So valproate interferes with the urea cycle. That's the system that clears ammonia. Ammonia builds up. Ammonia crosses the blood-brain barrier, and then the brain swells and malfunctions. So think of ammonia like exhaust fumes. The liver is the ventilation system, and the valproate blocks the vents. So the room fills with fumes even though the walls look fine. Early symptoms can be subtle here. So look on the left side here, you see confusion, lethargy, behavior change. This often gets mislabeled as depression or delirium or dementia. It is a delirium, but delirium is a medical emergency. So as it worsens, you'll start to see things like ataxia, tremor, vomiting. The patient can become unstable on their feet. Their speech may slow or slur. And if it continues, you can proceed to stupor, seizure, coma. This is a medical emergency. So here's the trap. Your patient on Depakote becomes confused and unsteady. You check the valproate level, it's 85. Someone says the level is normal. Well, that does not rule out toxicity. In fact, it should make you think harder. What should you do instead? Well, when mental status changes on valproate occur, that's the cue to check the ammonia level. Don't go randomly checking ammonia levels on everybody, because there's a percentage of the population that has a higher than normal ammonia and is doing just fine. So even if they're having symptoms, you check the ammonia if they're on valproic. Even if the dose is stable, even if the level is normal, even if the LFTs look fine. What you're doing is you're trying to validate the evaluation of that delirium altered mental status with a lab finding that explains it. So the total level does not equal brain exposure. The numbers do not equal physiology. So remember, you're always treating the patient, not the lab value. If the ammonia level is elevated with symptoms, then you stop the valproate and consider L-carnitine, and then you probably will need to escalate this to a higher level of care. Valproate acid toxicity is not just about serum levels, it's about metabolism and ammonia, and it's about recognizing the danger before the patient seizes. So I'm going to show you a little algorithm here to start when a patient on valproic starts to have new neurological signs and symptoms like confusion, lethargy, ataxia. Now sometimes these can be subtle, but other times it could be quite dramatic. Please don't wait for seizures to act. Now, you do not need a high valproate level to start this, and you do not need abnormal LFTs. You just need symptoms. So the next step is simple and often missed. So check the ammonia level. Even if everything else looks normal, normal liver enzymes don't rule this out. So ammonia is the decision-making lab here, not the valproic level. If your ammonia is elevated, you act. You don't watch and wait. You have to do something. So step one, stop or reduce the valproic acid immediately. That's not dose optimization. This is removing the offending agent, because if you don't stop the source, nothing else matters. Next, L-carnitine. Valproate depletes carnitine. Carnitine helps restore mitochondrial function and ammonia clearance. So doses of 50 to 100 milligrams per kilogram per day is the standard. That's not exotic. Okay. Step 3 is supportive measures, hydration. You want to optimize the renal clearance, and in some cases you may give lactulose. Not because this is liver, but because reducing ammonia load helps the brain. Now look at this red box here. This matters a lot. If the patient has coma or seizures, you are way beyond routine management. Call the ICU, because hemodialysis may be required. Dialysis will remove ammonia and valproate and hopefully save lives. So what's missing from this algorithm? There is no step in this algorithm that says recheck the valproate level first. There's no step that says wait for LFTs to worsen. So valproic hyperammonemic encephalopathy is diagnosed clinically and supported by the ammonia level. The treatment is immediate and decisive, and the aim is to reduce seizures and coma. So when the mental status changes, think ammonia, stop the drugs, support the clearance, escalate, and that's how you protect the brain. All right, now we're going to talk about clozapine. Now this slide is about why clozapine is both a powerful and unforgiving drug. This works when nothing else does, but only if you follow the rules. Now this is not suggestions. These are safety gates, okay? So you start here with this big picture that clozapine is unique among the antipsychotics. Why? Well, it reduces suicide risk, and it treats true treatment-resistant schizophrenia, and it can cause life-threatening neutropenia. So this is why monitoring is mandatory, even though guidelines may have changed. Okay, so the ANC initiation. So before the first dose, you have to check the ANC, absolute neutrophil count, and it has to be at least 1,500. If it is, that's your green light. Now, what's the problem? Well, there are some people that have a condition called BEN. BEN? Benign ethnic neutropenia. It's the one exception. So patients of African, Middle Eastern, or West Indian descent may have a naturally lower baseline ANC. In those patients, you can start clozapine at 1,000 per microliter. This does not mean higher infection risk. In fact, that's how you tell. They have this lower neutrophil, but they don't have frequent infections. This is just a normal variation in that populations. So the danger is assuming that neutropenia equals pathology. Benign ethnic neutropenia is physiology, not disease. So next, once the clozapine is started, your clock starts running. For the first 6 months, you need to check a weekly ANC level. And then from 6 to 12 months, you're checking it every 2 weeks. And then after 12 months, assuming they're stable, you can go to monthly. Here's the trap that you might miss. If clozapine is stopped for more than 30 days, you need to restart the entire monitoring schedule, going back to weekly again. The risk resets. So now, when do you interrupt therapy with clozapine? This is where people get nervous. If the ANC drops below 1,000, you need to interrupt therapy. For people with benign ethnic neutropenia, which you should clearly document, that cutoff goes below 500. This is severe neutropenia, also known as agranulocytosis. So at this point, the medication does not matter. What matters now is the bone marrow. Now, clozapine also has a measurable serum level, and that therapeutic range is roughly between 350 to 600 nanograms per milliliter. So below that, generally ineffective, and above that, the risk really goes up. So unlike lithium, this level is not for routine safety monitoring. It's to mainly use to confirm adherence or explain side effects. But once you go above 600, seizure risk greatly increases. And above 1,000, you are in toxic territory. So a normal clozapine level does not protect you, by the way, from neutropenia. Those are separate risks. You need to monitor both, but for different reasons. Benign ethnic neutropenia clinically matters. Mislabeling benign ethnic neutropenia as a pathology, though, will deny some patients access to clozapine, and that's not minor, because that's outcome changing, because by the time you get to clozapine, you have failed at least 2 other antipsychotics. Now, clozapine works because it's different. It's monitored because it's dangerous, and when used correctly, it can save lives. Now, benign ethnic neutropenia is so important, I'm going to spend a little bit of time on this. And I don't want you to deny the right patient the right medication. So, benign ethnic neutropenia means that a person has a lower baseline neutrophil count, but their immune system works normally. They're not immunocompromised, they don't get more infections. Who does it affect? Well, commonly African, Middle Eastern, and West Indian descent, and it's linked to a genetic variant, the Duffy null phenotype. Now, that variant affects how neutrophils circulate and how immunity functions. So do not deny clozapine based on normal lab ranges. Normal ranges were not built for every population. So using the Ben-specific thresholds prevents this healthcare disparity. Now, how is it diagnosed? So step one, you look at the pattern, not a single lab. So Ben is not diagnosed from one low ANC. You look for chronically low but stable neutrophil count, typically between 1,000 and 1,500. And it stays there over time. So maybe you do collateral and call the primary care and look at some past CBCs that they may have had done in the past. Step two, you check the clinical context. Ask a simple question of the patient or the ones that know them well. Does this patient have recurrent or unusual infections? If the answer is no, that supports benign ethnic neutropenia. Also, you want to rule out physiological causes because Ben is a diagnosis of exclusion. You need to rule out things that actually cause neutropenia, right? That includes things like acute infections, bone marrow suppression, chemotherapy, autoimmune disease, other offending medications. So you're going to use history, not race alone. Because you don't diagnose Ben based on race alone, you need to do a history, check labs, and confirm the absence of illness. The ancestry may simply raise the index of suspicion, but it doesn't make the diagnosis. And of course, you must document this clearly, especially if you go on vacation and someone's covering and they need to refill the clozapine, because once Ben is identified, it needs to be explicitly documented. Don't write borderline labs, not chronic neutropenia. Write out fully benign ethnic neutropenia and say it out loud in your handoff, because this protects the patient from an inappropriate discontinuation later on. So for most patients, clozapine starts at greater than or equal to 1,500. For Ben patients, the cutoff is 1,000. Same monitoring schedule, but different stopping rules. These patients are not immunocompromised. Their lower ANC is physiologic, not pathologic. So treat the patient, not the reference range, because your job as a prescriber is to recognize Ben, document Ben, and apply the correct thresholds every time. Clozapine is already underused. Misunderstanding Ben makes that situation worse. So this is not just good medicine, but fair medicine. Okay, let's talk about lithium, the gold standard for bipolar disorder. It is also the gold standard for how not to be sloppy with your labs, because if you don't respect timing with lithium, you will be punished. Now, the standard therapeutic range is 0.6 to 1.2. In acute mania, it can be pushed to 1.5, but only with close monitoring. That's not a casual decision, okay? And timing is non-negotiable. So how long from the dose after 5 half-lives? Lithium levels are meaningless unless they are 12-hour troughs. Not 10, not roughly overnight, 12 hours. So you give this medicine at 9 p.m., draw the lab at 9 a.m. Anything else, and the number is suspect, okay? Lithium is not a lab. It is a measurement under strict conditions. So change the conditions and you change the meaning. So before you adjust the dose, ask yourself, can I trust this number? So if the patient took lithium before the blood draw, you may have measured a peak, not a trough, and that will falsely elevate your number, and you might think the patient is toxic when they're not. If the patient skipped the dose, the level will be artificially low, and you might increase the dose unnecessarily, and then you made them toxic. Lithium is cleared almost entirely by the kidney, so anything that affects the kidneys, NSAIDs, thiazides, ACE inhibitors, loop diuretics, all of those will raise the lithium levels even if the dose doesn't change, and be careful to interim dosing like they stopped at urgent care in the time between the CRU, okay? So when lithium changes, ask why before you ask how much. Lithium doesn't just affect mood, by the way, it affects organs. So you need to be checking creatinine at least every 6 to 12 months, more often if they're older or medically complex. The TSH level at least every 6 to 12 months because lithium can induce hypothyroidism and patients won't always complain. It can also cause hyperthyroidism. Also, calcium and parathyroid. So check calcium at least every 6 months. Lithium can cause hyperparathyroidism. That's not trivia. That's just a long-term morbidity that's going to happen. And sometimes you treat the comorbidity and continue on with the lithium. All right, so let's talk about pharmacogenetics versus pharmacogenomics. What is the difference between these? It's important we clarify. So pharmacogenetics asks the question, how does a specific gene affect this drug? And pharmacogenomics asks, how does the entire genome shape the drug response overall? One is focused, the other is big picture. Pharmacogenetics is looking at a single gene approach. We're looking at one gene, usually an enzyme, and we ask how variations change drug metabolism or response. So think of this like checking one worker on an assembly line, right? If that worker is slow or fast or missing, the production will change. Now, most pharmacogenetic testing, PGX, pharmacogenetic testing in psychiatry is focusing on CYP2D6 and CYP2C19, right? So tricyclic antidepressants, say, are metabolized through CYP2D6. Now, if someone is a poor metabolizer, that drug is going to build up in their system. If they're an ultra-rapid metabolizer, that drug is going to disappear very quickly. Pharmacogenetics is most helpful when, that is to say, when should I consider doing this test? If you see unexpected side effects, or if you do not get a response at normal doses, or if there's a history of medication sensitivity or repeated failures, that would be a good time to consider pharmacogenetic testing. Now let me shift to pharmacogenomics, okay? This is the zoom out. This is supposed to be genome-wide. We're no longer asking about one enzyme. We're asking how many genes together influence the response, right? We're not now looking just at one factory worker. We're evaluating the entire factory, the whole multiple workers, the whole production line. We're looking at interactions and bottlenecks and feedback loops, right? And what we're looking to capture is drug metabolism, drug targets, transporters, receptors, and sometimes disease risk itself. So why this matters clinically is that drug response is rarely driven by one gene alone, right? Efficacy and toxicity will often emerge from combined genetic effects. So that's why pharmacogenomics is more complex and much harder to act on cleanly. Now, in everyday psychiatric practice, most of those commercially available tests are marketed as pharmacogenomic. But actually, they are really just pharmacogenetic panels. What they're testing is multiple individual genes, not true whole genome sequencing. So pharmacogenetics helps you answer the question, why did this drug behave strangely in this patient? And pharmacogenomics tries to answer, how will this patient generally respond to drugs overall? Both of these are tools not meant to replace your clinical reasoning, right? It's not meant to be a paint-by-numbers approach. So genetics does not prescribe the drug for you, and it doesn't override history and symptoms or side effects. It's supposed to give you context, not commands. All right, now this slide explains why genetic tests reports will often confuse clinicians and why some people think pharmacogenetics are useless. The problem is not the science, it's just a failure to translate. Genotype is the raw genetic data. It's the specific alleles a patient inherits. Star alleles, numbers, letters. For example, CYP2D6 star or asterisk 4/4 asterisk 4. Okay? Or CYP2C1922. So genotype by itself is not actionable. It tells you what the DNA says, not what the enzyme actually does in practice. Phenotype is what the gene means functionally. It's the predicted enzyme activity. This is where we translate DNA into behavior. So you will see some common phenotypes. There are 4. You can be a poor metabolizer, an intermediate metabolizer, a normal metabolizer, or an ultra-rapid metabolizer. So clinicians should think in phenotypes, not genotypes. You don't dose based on star alleles. You dose based on enzyme function. So what you need to do is, this is where most errors happen, is in the clinical translation. So people stop at phenotype, but phenotype still doesn't tell you what to do. So what translation actually is, clinical translation means applying evidence-based guidelines, not vibes, not intuition, guidelines like the CPIC and FDA labeling. So what these guidelines do is they tell you when to avoid a drug, lower the dose, increase the dose, or proceed normally. So let's walk this straight down. So you see on the right side there, genotype CYP2C1922. Okay, that genotype predicts poor metabolizer status. So here comes the clinical decision. So if clopidogrel is a prodrug and it requires the CYP2C19 to become active, poor metabolizers cannot activate it. So what do? So the action here is not to monitor. The action is to avoid clopidogrel. So you choose a different antiplatelet medication. So precision medicine doesn't mean perfection. It means reducing avoidable harm and matching the right drug at the right dose to the right patient when genetics matter. Most psychiatric prescribing will not hinge on genetics. But when genetics matter, they matter a lot. And that's especially true in things like tricyclic antidepressants, certain SSRIs, antipsychotic side effects, unexpected toxicity or non-responders. So the take home in all of this is this: genotypes are data, phenotypes are meaning, and clinical translation is your responsibility. Alright, so let's talk about metabolizer phenotypes, what to expect and what to do. Now, some people process drugs slowly, and some people process them normally, and others process them very fast. And those differences change the exposure, not the intent of the drug. So poor metabolizers have reduced enzyme activity. That is to say, the drug gets cleared slowly. So what that means is levels build up. So if you give a standard dose, the body treats it like a high dose. So that's why side effects will happen early on. So you may give, say, nortriptyline in a CYP2D6 poor metabolizer. They don't need more drug. They already have too much. And the risk here is toxicity, not just failure to respond. So you'll see sedation and increased QT prolongation and anticholinergic effects. The normal metabolizers are also called extensive normal metabolizers. The phrase bothers me. I didn't write it. That's how it is. Learn the term. Extensive means normal metabolizer. So this is the group that the drug trials are designed around. They are designed around normal enzyme activity and normal exposure. So if a drug works as expected, this is usually why. So what you'll get here is you'll get the effect that you planned for, no surprise, no mystery. The third category are these ultra metabolizers, right? This flips the problem. An ultra rapid metabolizer clears the drug too fast, so the drug doesn't stay around long enough to actually work. So you prescribe, they take it, nothing happens. That's how that would go. So think of something like escitalopram or venlafaxine, right? CYP2C19 or CYP2D6, ultra rapid metabolizer. They're not non-adherent. They're just underexposed. So the risk is treatment failure, not side effects. The prodrug is where people get burned. Prodrugs flip the script. So a prodrug is the inactive when swallowed. It has to be activated by the enzyme. For example, codeine needs CYP2D6 to become morphine. Well, if you're a poor metabolizer, nothing there to flip the switch, you get no pain relief. If you're an ultra-rapid metabolizer, you convert the codeine to morphine too fast and overdose at normal doses. What about something like street drug, say? Take whatever street drug you can think of, right? Same substance, same amount, very different outcomes. Someone takes a little of something and fine. Other person takes it, overdose, and dead. We don't know how their metabolism and their phenotypes are. So remember this rule. Metabolizer status predicts exposure, not mortality. It explains why the patients aren't difficult, they're just different. So poor metabolizers are getting too much drug, ultra-rapid metabolizers are getting too little drug, and prodrugs reverse that risk. So CYP2D6 is one of the most clinically important enzymes in psychiatry and pain medicine, and it causes problems in both directions. So if 2D6 is responsible for metabolizing a wide range of psychotropics, some are already active drugs, while as others are prodrugs that have to be activated. So some major substrates like 2D6 drugs include things like tricyclics, i.e. nortriptyline, or SSRIs like fluoxetine, or antipsychotics like aripiprazole or risperidone, and importantly, codeine and tramadol. Poor metabolizers, these have low CYP2D6 activity. So these drugs are processed by the 2D6 and they hang around longer. So for active drugs like aripiprazole or nortriptyline, levels will rise. The side effects are going to appear early. So this is why the CPIC recommends dose reductions, often by about 50%. So if a patient gets akathisia on a very low dose of aripiprazole, that's not sensitivity, that's pharmacogenetics playing its part. Prodrugs in poor metabolizers flip this. A prodrug in a poor metabolizer like codeine needing 2D6 to work, if they're a poor metabolizer, they don't get activation, they don't get morphine, they don't get pain relief. So the bottom line for all this is poor metabolizers, they get active drugs, they have toxicity risk. If they get prodrugs, they don't get any benefit, treatment failure. So in this case, you'd avoid codeine. Ultra-rapid metabolizers, they set up the contrast here, right? So ultra-rapid metabolizers have too much CYP2D6 activity. They clear drugs fast or activate prodrugs dangerously fast. So for example, for active drugs, the level will fall too quickly. The medication doesn't work. That's not non-adherence. So an SSRI that never helps despite adequate dosing, that should be a clue. Now, prodrugs are dangerous because prodrugs like codeine and tramadol, they can get converted too fast. So you may have suddenly high morphine levels, and that's how overdose happens at just normal doses. So this is a prodrug trap. Look at the box on the right. The box on the right is worth memorizing because it shows why CYP2D6 is uniquely dangerous. Codeine and tramadol rely on CYP2D6. Poor metabolizer, no pain relief. Ultra-rapid metabolizer, overdose risk. So if CYP2D6 status is unknown or risky, don't guess. Just use a non-CYP2D6 opioid, like morphine. hydromorphone, already ready to go. So in the real world, the same mechanism explains why people respond unpredictably to opioids. Same drug, same dose, just very different biology. So CYP2D6 problems are bidirectional. Poor metabolizers get toxicity from active drugs and no effect from prodrugs. Ultra-rapid metabolizers get treatment failure or overdose. Okay, now we're shifting from 2D6 to 2C19. Now this enzyme matters most for SSRIs for one very important cardiac drug. And again, you're going to see the same two themes: dose problems and prodrug failure. So CYP2C19 and SSRIs, the main psychiatric drugs here are escitalopram and sertraline. Okay, these are major CYP2C19 substrates. A poor metabolizer of a CYP2C19, poor metabolizer, they clear the SSRIs slowly. So blood levels rise and side effects show up early. This is why the recommendation is to reduce the starting dose by about 50%. So always start these drugs low, just in case, and we haven't done the test yet, and they don't have too many symptoms, and then all of a sudden, they want to abandon ship because it's too many adverse effects. So if a patient reports nausea, agitation, sedation at very low doses, that's not intolerance, that's metabolism. So ultra-rapid metabolizers, now the opposite, right? Ultra-rapid metabolizers clear that SSRI so fast that the drug never reaches an effective level and the medication looks like it doesn't work. That's not treatment resistance, it's underexposure. So it's important we not mislabel the patient because they're very sticky, those labels. The QTC issue here. So citalopram and escitalopram carry QTC prolongation warnings. That means higher levels aren't just uncomfortable, they can be fatal. So metabolic status matters even more with those drugs. Now let me talk about 2C19 and clopidogrel, because this is high stakes. Now let's talk about clopidogrel, also known as Plavix. This is a prodrug. Has to be activated by the 2C19 pathway. So if you are a poor metabolizer and the 2C19, they cannot activate clopidogrel. So that means they're not really getting clopidogrel. They're not really having platelet inhibition. That's treatment failure. So the lab value can look perfect, the prescription correct, and the patient can still develop a clot. So in these patients, the answer is not dose adjustment. The answer is switch drugs. You could use Ticagrelor, the heck is it? Ticagrelor or Parasugrel, because those two drugs will bypass the 2C19 entirely. Okay, so let's answer the question on the right. How would you counsel a CYP 2C19 poor metabolizer about starting escitalopram? What might you say to them? Well, if you've been listening, paying attention, and retaining, you might say that their body processes this medication more slowly. And so as a result, we're going to start at a lower dose, and we're going to go slowly and watch carefully for side effects, especially early on. And then this is not weaker treatment, just a safer approach. Okay? So CYP2C19, poor metabolizers get too much SSRI and no clopidogrel effect. You might see that on a test somewhere. And ultra-rapid metabolizers of the 2C19 get too little SSRI. All right, let's talk about this one. So CYP1A2. So a CYP1A2 is a liver enzyme, and it metabolizes several key psychiatric medications, most importantly clozapine and olanzapine. And unlike most CYP enzymes, it's powerfully affected by environmental exposures. So What causes these effects? So the inducer here would be something like tobacco smoke, specifically that polycyclic aromatic hydrocarbon produced by combustion, not the nicotine. Since we don't have smoking in the hospital, and most of our people on these meds smoke, that could explain why they decompensate immediately upon going out, even though we give them a nicotine patch. So this means nicotine patches and gums and vaping, they don't cause the effect. It's the actual cigarette. So smoking induces the CYP1A2, and that means that the enzymes works faster, and the drugs are cleared more quickly, and therefore the blood levels go down. So a patient who smokes may need a higher dose of clozapine or olanzapine to get the same effect. Otherwise, the medication looks ineffective. So here's the danger part. So when a patient stops smoking, the enzyme induction turns off, and it turns off fast. Same dose, same prescription, but suddenly a much higher blood level. So this is why the slide says smoking induction reduces drug levels and quitting causes levels to spike rapidly. This is not subtle. This can cause toxicity within days. So imagine a patient stable on clozapine who's smoking a pack a day. They get admitted to the hospital, no cigarettes, no dose change. What might happen? So within a few days, they're going to be sedated and drooling and confused and possibly have seizures. So maybe that's the case to bring back smoking rooms in the psych wards. Now, everyone is confused unless you know this. The dose did not change, but the metabolism did. So this is why smoking status is not a social history detail. It's a major pharmacokinetic variable. So you should ask about it at every visit. So if a patient's on clozapine and stops smoking, you're usually going to need to reduce the dose and monitor levels closely. So smoking and the CYP1A2 gets induced, and the induction means faster metabolism, and faster metabolism means lower drug levels. No smoking, no induction, slower metabolism, higher levels. So smoking lowers clozapine and olanzapine levels. Stopping smoking raises them. Nicotine replacement does not count as smoking. So when clozapine toxicity appears out of nowhere, did anything change with smoking? Should be your thoughts and questions. Now this slide's about why warfarin is one of the most unforgiving drugs in medicine and why psychiatry can destabilize it without meaning to. So warfarin dosing is highly dependent on genetics. Now two genes matter most, the CYP2C9 and the VKORC1. Now the CYP2C9 is the primary enzyme that metabolizes warfarin. Variants like the STAR2 and the STAR3 reduce enzyme activity. So that means slower clearance and higher warfarin levels at standard doses. The VKORC1 doesn't affect metabolism. It affects sensitivity to warfarin. And variants make patients more sensitive to the same plasma level. So a patient with a CYP2C9 and or a VKORC1 variant can bleed at what looks like a normal dose. So the textbook 5 mg start can be dangerous. Standard dosing can produce a supra-therapeutic INR and major bleeding. So that's why genetic testing, when available, often points to starting at 1 to 2 milligrams and not 5 milligrams, especially in older adults. Now take a look at the right side of the screen here. So now if we add psychiatry into the mix, this is where the INR instability often begins. So inhibition, fluoxetine and fluvoxamine are strong CYP2C9 inhibitors. They slow warfarin metabolism and INR goes up. Protein binding displacement happens when valproate displaces warfarin from the albumin. So the total level may look unchanged, but free active warfarin now has increased. So this is the same concept you learned with valproate free levels, only now the consequence is bleeding. So when a psychotropic is added or adjusted, know that the INR can spike rapidly, sometimes within days. So this is not a reason to avoid treating the psychiatric illness, but it is a reason to coordinate care and increase INR monitoring when you start, stop, or change these medications. Warfarin risk is genetic and pharmacologic, and SSRIs can inhibit metabolism, and valproate increases free drug, and dose stability does not mean safety. So if a patient on warfarin suddenly has an INR spike, you need to ask, was a psych med added, stopped, or adjusted? Well, pharmacogenetics can save lives. This one is not about optimizing treatment as much as it's about preventing catastrophe. So some drug reactions are not dose related. They are immune mediated. And once triggered, you can't stop. The one I'm talking about here is the HLA-B star 1502. The HLA-B 1502 is a genetic risk allele found most commonly in people of Asian ancestry, Han Chinese, Thai, Malaysian, and Southeast Indian populations. Now, in patients with this allele, carbamazepine can trigger Stevens-Johnson syndrome, or TEN. So this is not just a rash. This is a skin necrosis which can be fatal. So the immune system misidentifies the drug-protein complex as a threat, and then the T cells start to attack the skin and the mucous membranes. And once it starts, stopping the drug may not stop the process, but that is still part of the treatment. HLA star 3101 is a broader hypersensitivity risk allele, and it's associated with DRESS and Stevens-Johnson and other severe rashes. It's more often seen in people who are Japanese, European, and Korean populations. So this allele is still most strongly associated with carbamazepine. But the reaction spectrum is a lot wider. It's not just Stevens-Johnson syndrome and TEN, okay? So because of the risk, screening is mandatory before starting carbamazepine, oxcarbazepine in the risk populations. This is not optional. This is standard of care. So if a patient is positive for HLA-B star 1502, you do not try a lower dose. You do not titrate slowly. You just avoid the drug entirely. Avoid carbamazepine and oxcarbazepine and avoid phenytoin and use extreme caution. So alternatives would be things like valproic acid, lamotrigine can be used, but it requires a slow titration for different rash risks. The other thing you want to know about here is lamotrigine rash risk is not driven by this specific HLA allele. This is a risk dose titration dependent situation, and that's a completely different mechanism. Okay, so HLA-B star 1502 plus carbamazepine equals absolute contraindication, no shared decision making, no risk-benefit debate, do not pass go, do not collect $200, go to jail. Okay, so this is one of the few places in psychopharmacology where genetics gives us a clear red light, and genetics says stop, we stop. So before we start this slide, it's important to know that this MTHFR is all over the social media, TikTok, functional medicine, blah, blah, blah. Okay, MTHFR is not a diagnosis. It is not an explanation for every psychiatric symptom, but it can matter in specific, biologically coherent ways. So what MTHFR actually does is this enzyme converts dietary folate, what you eat or take by pill, into L5-methyltetrahydrofolate. That is the active form. And that active form is the one that can cross the blood-brain barrier. So think of folic acid as raw ingredients, and MTHFR is the machine that turns those ingredients into something usable. So if the machine is slow or broken or pilling, or one or more ingredients doesn't fix the problem. So this pathway feeds directly into methylation. Methylation is not abstract biochemistry, it's the engine behind neurotransmitter production. Like what? Like serotonin, dopamine, norepinephrine, etc., right? So if methylation is inefficient, monoamine synthesis may be reduced, and that can show up as poor antidepressant response, cognitive slowing, fatigue, or emotional blunting. Think homocysteine. When MTHFR activity is low, homocysteine levels tend to rise. Homocysteine is an inflammatory and neurotoxic product, and this is one of the few lab markers that can give you a functional readout of this pathway. So for example, this is not about chasing SNPs. This is about understanding a bottleneck in the system. So here's the key question. If a patient has severe MTHFR dysfunction, why might giving very high doses of standard folic acid be ineffective or even counterproductive? Because folic acid still has to go through the same broken enzyme system. You're just pouring more traffic into a closed tunnel. You don't get more flow, you get more congestion. So more is not always better. Biology really cares about the pathway, not your intentions. So it does not mean, though, that everyone needs genetic testing. It does not mean folic acid is harmful in general. And it does not mean MTHFR explains treatment-resistant depression by itself. MTHFR matters when the clinical picture, that is to say labs and treatment response, line up. So used thoughtfully, it can explain why something is not working. Used carelessly, and this becomes bro science or pseudoscience. Alright, so let's interpret a report. So when you receive a pharmacogenetic report, you're not just looking at one result, you're looking at layers of information that need to be interpreted in the right order. So think of it like reading a weather report. The raw data matters, but what you do with it matters even more. So the first thing you need to do is confirm the relevance. Not every gene matters for every drug. So just because the report lists something like a CYP2D6 and 2C19 and 1A2 does not mean all of them are clinically important for the medication you're prescribing. So for example, 2D6 is the major pathway for paroxetine, assuming we're still using that. But it's only one minor pathway for citalopram. So a 2D6 poor metabolizer status is a big deal if you're prescribing paroxetine, and often a much smaller deal for citalopram. So this step prevents overreacting to genetic data that isn't actually driving the drug's behavior. The next thing to look at here is adjustment management. Second, adjustment management, not reflexively though, but thoughtfully. So now you use the phenotype, not the raw genotype, to guide your decision. So if someone is a poor metabolizer, that usually means higher drug levels, higher side effect risk. So you reduce the dose or choose an alternative. And if someone's an ultra-rapid metabolizer, that often means the drug clears too fast and you're going to have an inadequate response. So you may need either a higher dose or a different medication altogether. And this is where guidelines like the CPIC and the FDA guidance come in. You're not inventing dosing. You're just applying an established clinical framework. Now, you always need to document the rationale. This is critical and crucial, and you're documenting your reasoning. You want future clinicians to understand why did you make the change you made, not just what you did. So instead of writing something as uninformative as dose reduced, You would write dose reduced due to CYP2D6 poor metabolizer status. That single sentence protects the patient and you and prevents future unnecessary retrialing of drugs that had already failed for a biological reason. Now this slide answers a very practical question. When is genetic testing actually worth doing? Because the honest truth is not every patient needs a pharmacogenetic test, right? Pharmacogenomic test. The goal is not to test more. The goal is to test when it's going to change what you do. So take a look at the left side here. These are high yield scenarios in which testing might matter a lot. So first, of course, safety risk. So if you're about to prescribe a high stakes drug and a genetic test result could prevent serious harm, testing is essential. And the classic example is the carbamazepine in Asian ancestry. Okay, where the HLA-B 1502 predicts something like Stevens-Johnson syndrome. In those cases, testing isn't optional. It's protective, okay? Second would be treatment failure or unusual side effects. So if a patient has failed multiple standard trials or is having side effects that don't match the dose, that signal, that's something biological may be off. Okay, and this is where pharmacogenetics can explain why normal doses are causing toxicity or why medications seem to do nothing. The third is polypharmacy. So when a patient's on multiple medications and multiple metabolic pathways, and they can start interacting. So that's why CYP inhibition, induction, and phenoconversion make clinical behavior unpredictable. And pharmacogenetics there can help you simplify and rationalize the regimen. So here's the clinical rule I want you to remember. If the test result would stop you from prescribing a dangerous drug, then you should order the test, and that's the threshold. The right side is this cost-benefit check. Let's talk about some restraint. So before ordering a genetic test, ask yourself, will this result change my plan today? And if the answer is no, then maybe you want to pause. Also, economics. Most pharmacogenetic panels are expensive, although they are coming down in price. And you want to avoid ordering tests that simply add cost and create anxiety and undermine the therapeutic alliance. But they're not going to change the management, and low yield information is still low yield, so even if it looks impressive, may not be worth it. The other thing is you don't want to go fishing on expeditions here, okay? So straightforward treatment, naive patient, one diagnosis, one medication, no red flags. Genetic testing is often going to add noise, not clarity, right? Now, this is where clinical judgment comes in first. So what people are doing now is setting up telepsych practices remotely, and from the intake they're doing this, and it's a complete cash practice, and people like this because they don't want to bother with the trial and error, and they could wait on the time for the results to come back. That's a treatment clinical judgment. So if it comes back as a poor metabolizer, do I already have a plan B? Right? What are you doing with the results? If you don't have a plan B, then you're not ready to order the test. So pharmacogenetics is a tool, but it shouldn't be a reflex, and it should be used thoughtfully because it can prevent harm. If you use indiscriminately, it can distract you from clear reasoning, and the best clinicians don't test more, they just test better. All right, let's walk through a real clinical scenario and watch how genetics explains everything that looked confusing. So here is a patient. She's a 45-year-old woman with persistent depressive symptoms who tells you medications make me sick. Now that phrase should already raise suspicion. She's on nortriptyline 25 milligrams, which is a low dose, plus lisinopril, which is irrelevant here. And nothing about this regimen should be causing these severe side effects, and yet she is saying that they are, right? So now look at the data. Her genotype for the CYP2D644, which means she is a poor metabolizer, right? So she has essentially no functional CYP2D6 activity. Now look at the serum level here of 180 nanograms per milliliter. That's above the therapeutic range on a low dose. So that's the teaching moment. This is not a dosing problem. This is a metabolism problem because the 2D6 is the primary metabolic pathway for the nortriptyline. So what happens is the drug accumulates and the levels rise disproportionately, and she might be having anticholinergic side effects which appear early and severely, which is explaining the dry mouth and the constipation and the belief that the meds make her sick. She's not sensitive. She's genetically unable to clear the drug. So what do? Well, stop the nortriptyline. That's no longer a titrate and watch situation. This is a toxicity situation. And then what do? Well, we choose a different pathway. So we switch to an antidepressant that does not use the CYP2D6. So like what? Desvenlafaxine, mirtazapine, right? The goal is not just symptom relief, it's predictable pharmacokinetics. Could you keep the TCA in this case? Technically, yes, but rarely, because if you did, you would be aiming for 50 to 150 nanograms per milliliter, likely at a very low dose with close serum monitoring. But in real practice, the smarter move is just change the drug class. So this is the big lesson. When a patient has side effects at low doses, don't assume anxiety, intolerance, non-compliance, or bad therapeutic alliance even. Consider that this is a poor metabolizer. Is this drug pathway dependent? Because sometimes the problem isn't the medication. It's the enzyme that's missing. So a CYP2D6 poor metabolizer on nortriptyline will experience toxicity at standard or even low doses due to impaired clearance. That sentence alone is going to get you points on an exam and maybe save you patience in practice. All right, let's start with another case here. So here's a 28-year-old man of Han Chinese descent, diagnosed with bipolar I disorder, currently in a manic episode, and the plan on the table is to consider starting carbamazepine. Now, it shouldn't be that way because it should just be an easy fix. But clinically, that makes sense until the genetics enter the room. Now, take a look at the screening here. He tested positive for HLA-B1502. This is not a dose adjustment gene. This is not a monitor closely gene. This is a do not cross the line situation. So let's be very clear about the risk. HLA-B1502 positivity is associated with Stevens-Johnson syndrome and toxic epidermal necrolysis 10, okay? So these are life-threatening, often rapid onset, and often fatal or permanently disabling. And here's the key thing. This risk exists even at low doses, even on first exposure. This is not a start low and go slow way out of this, okay? So what's the correct action? Do not start the carbamazepine. It's contraindicated, full stop, okay? There's no safe workaround here. So you still need to treat the mania, so you're left with things like, lithium and valproate, with standard monitoring of LFTs and platelets and serum levels as indicated. These agents don't carry that same HLA-linked risk. So the final step is documentation. You must update the allergy list here. Explicitly note carbamazepine hypersensitivity risk, because this will protect the patient years later when different clinicians open the chart and consider a mood stabilizer. This is genetic information that never expires. So this is a great example of when genetic testing changes the management before the first dose. So this patient never had a rash, never had a reaction, never took the drug, right? And yet the correct decision is to never try it. That's when pharmacogenetic testing is a good useful thing. So in patients of Asian ancestry who are HLA-B positive 1502, carbamazepine is contraindicated due to a high risk of Stevens-Johnson and 10. So if you remember one sentence, please remember that. Okay, some genetic tests help you fine-tune treatment. Others, like in this case, save lives. All right, let's do another case. So this is a 35-year-old male presenting with treatment-resistant depression, and he's failed 2 SSRIs, and the current medication includes sertraline 200 milligrams, and he only has a partial response. So this is not about underdosing, right? This is not about non-adherence. This is not a weak antidepressant. Something upstream is wrong. Now we look at the genetic data and we look at the genotype and we have this MTHFR C677T homozygous. Now, this variant reduces the MTHFR enzyme activity by about 70%. And we have biological confirmation with a homocysteine level of 16. So that tells us the pathway disruption is functionally active, not just theoretical. So why this matters? This is not about depression genes. MTHFR does not cause depression. What it does is it creates that methylation bottleneck. So if methylation is impaired, the monoamine synthesis is inefficient, and antidepressants can block the reuptake all day long, but there isn't enough neurotransmitter being made upstream. So SSRIs aren't failing, they're starved of substrate. So this is why more folic acid doesn't help, and standard folic acid requires MTHFR to be converted, which this patient cannot efficiently do. So giving folic acid here is like pouring water that's into a pipe with a closed valve, right? It's blocked, it just backs up. So what do? Well, we bypass the defective step altogether. So what do? You augment them with L-methylfolate, right? Give them 15 milligrams a day. In addition, this will cross the blood-brain barrier, enters the methylation cycle downstream of the MTHFR, and it will support the monoamine synthesis directly. This is not supplementation anymore. This is biochemical rerouting, okay? So we don't stop at one enzyme. In addition, if this is a problem, you need to also support B12 and vitamin B6. Why? Because methylation is a team sport. Fixing one bottleneck while ignoring the cofactors is going to limit the response. This, by the way, is not an overnight fix. You're going to need to reassess mood and energy and cognition symptoms at about 8 to 12 weeks. And often what you will see is the SSRI suddenly starts working, and partial responders now become full responders, and fewer medication changes are needed, right? This is not alternative medicine. This is L-methylfolate, has randomized controlled trials and FDA-regulated formulations. There's a clear biochemical rationale, right? That's precision augmentation. Now, some people will say, let's just put it on them. It's water-soluble, and the drugs are cheaper than the test. It's a clinical decision to make and decide on with your patients. In patients with treatment-resistant depression and homozygous MTHFR C677T variants, L-methylfolate augmentation can bypass impaired methylation and improve antidepressant response. So if you remember anything, just that. All right, let's talk about clozapine and benign ethnic neutropenia. So scenario one, we've got a patient of African descent with a diagnosis of schizophrenia who clearly needs clozapine, okay? And the ANC comes back at 1100. Now this is where people are going to panic. So this is not a granulocytosis. This is not clozapine toxicity. This is BEN. Benign ethnic neutropenia is this genetic baseline variant, right? Not an immune compromise, not increased infection risk. So if you apply the standard lab cutoff, you are going to mislabel this normal variant as pathology and deny the most effective antipsychotic we have, and create this health disparity. So what do? Proceed with the clozapine initiation here, right? Use the BEN-specific threshold, so an ANC of greater than or equal to 1,000, and do not discontinue in this case unless it drops below 500. So you treat the patient, not the reference range. And on the second case here, we have this valproate hyperammonemic encephalopathy, right? Case number 2. This one fools people. So on divalproex ER, the patient develops acute confusion, ataxia, and looks delirious. Maybe even looks like worsening mania. That's everyone's instinct, right? So they want to increase the antipsychotic, they want to add a benzo, they want to CT the head. Okay? But pause a minute. The valproic acid level here is 85, normal. The ammonia level is greater than 80, high. Here's the trap. You can have valproate toxicity with a normal valproate level. This is hyperammonemic encephalopathy. Valproate disrupts the urea cycle and the ammonia rises and then the brain function drops. It mimics psychiatric deterioration. So the fix is medical, not psychiatric. So you want to hold the valproic acid immediately and start the L-carnitine, and then you monitor the mental status closely. Do not escalate the psych meds. Don't assume non-compliance, and don't miss reversible causes of encephalopathy. Notice the through line here. So case 1, the lab looks scary, but the patient is actually fine, so don't overreact. In case 2, the drug level looks fine, but the patient is actually toxic. Don't underreact. So this is the clinical reasoning, not the cookbook checkbox psychiatry that sometimes abounds. So benign ethnic neutropenia, lower ANC thresholds apply, don't deny the clozapine. Valproic encephalopathy, hyperammonemia encephalopathy, normal valproate level does not rule out toxicity. Check the ammonia level. Just remember those two things. Treat the patient. All right, we're starting to review. So on the left, we have enzyme inducers. So think of the inducers as the accelerators. The inducers increase the production of the CYP enzyme. Not instantly, but over days to weeks, because the body has to make more enzyme. So the result is straightforward. More enzyme, faster metabolism, lower drug levels, reduced efficacy. So the risk with inducers is treatment failure, not toxicity. And the classic psych example here is something like carbamazepine, St. John's wort, smoking, right? Specifically through CYP1A2 induction. And on the right side here are the inhibitors, right? These are the braking systems. They slow down or block the enzyme, or either competitively or non-competitively. So this happens quickly, often within days. These results will flip completely. So all of a sudden you'll have higher drug levels and toxicity. So think of things like fluoxetine, valproate, ketoconazole, that once-a-week dosing that she took for a yeast infection on Wednesday, and you don't see her till Friday, and she forgets that she took the pill, but it's got such a long half-life, right? So inducers lower levels, inhibitors raise levels, but the clinical danger depends on the therapeutic index of the drug. So that's why this matters so much for things like tricyclics and clozapine and lithium and warfarin. Small changes can have huge consequences. So this is one of the highest yield interactions in psychiatry. Tobacco smoke, not nicotine, is the inducer of the CYP1A2. So if your patient stops smoking and the induction disappears, the enzyme activity drops and the clozapine level spikes. Okay, that's how you end up with sedation, seizures, and toxicity. And the reverse is also true. So if they restart the smoking, the clozapine level falls and the psychotic symptoms return. And this is why you have to reassess dosing whenever smoking status changes. And all of this goes back to pharmacogenomics. Your patient's genotype doesn't change, but their effective phenotype absolutely can. Add an inducer, add an inhibitor, change the smoking, and you've just created phenoconversion, even with normal metabolizers. So before you blame the diagnosis or the drug or the patient, ask yourself, did I just hit the accelerator or pump the brakes? Now this slide's about pattern recognition, not toxicology minute, okay? So when something goes wrong, you need to know what organ system is failing and what saves the patient. So let's look at some overdose management essentials. Tricyclic antidepressants. The first thing you need to think about is the heart first. They get a wide QRS complex and ventricular arrhythmias. That's sodium channel blockade, right? So the treatment is going to be sodium bicarbonate. Don't wait for the hypotension and the seizures and the widening QRS. It's already an emergency. With SSRIs, very different risk profile. Most overdoses are not lethal on their own. When it's dangerous is when they get something like serotonin syndrome. And the management for that is often supportive care, benzodiazepines for agitation, and cyproheptadine for if it's moderate to severe. Now, lithium. This one's deceptive because early signs of tremor, GI upset, confusion can look mild. But lithium causes renal failure and neurotoxicity if levels are high and the patient is symptomatic or renally impaired. In this case, you need hemodialysis. And valproate, you want to think ammonia, not just drug level. Patients can present with confusion and ataxia, and even when valproate levels look normal, the treatment is L-carnitine. Now, what about lamotrigine? Well, lamotrigine, the danger here is not overdose, it's rash, right? So SJS or TEN, you want to stop this drug immediately and never re-challenge. So unlike SSRIs, tricyclics and lithium have these narrow therapeutic indices. So a single 30-day supply can be lethal in overdose. That should influence what you prescribe, how much you dispense, and how closely you monitor. So this is not benign until proven otherwise. If you get a new rash on carbamazepine or lamotrigine, you need to stop the drug immediately and assess for mucosal involvement and assume the worst until it's ruled out and never re-challenge. If you see altered mental status on valproate, this is valproic hyperammonemia until proven otherwise. Check a stat ammonia level and don't be reassured by normal LFTs or therapeutic valproic levels. Treat first and confirm later. Lithium toxicity signs include GI symptoms plus a coarse tremor, ataxia. That's your warning. Hold the dose immediately, check the lithium level and renal function, hydrate aggressively, and if neurological symptoms are significant or renal functions impaired, you need to escalate. Now with clozapine, if you see sudden sedation, this is a danger signal, not a side effect. So you need to rule out myocarditis. Think tachycardia, chest pain in the early weeks, and ask about smoking cessation because the levels can spike rapidly. And always check for severe neutropenia. So with high-risk psychotropics, mild symptoms often precede the catastrophic ones. So when in doubt, hold the dose and investigate. So precision psychiatry is not about chasing genes and levels and algorithms. It's about integration. So the old model was one size fits all. The modern model integrates therapeutic drug monitoring, pharmacokinetics, and pharmacogenetics with the patient in front of you. So labs will give you context, not commands, and genes explain why something is happening, not what to do next by themselves. And the clinical presentation still makes the final call. So these tools that we've learned are here to sharpen your judgment and not replace it. So with therapeutic drug monitoring, you need to know when to order levels and how to interpret them. The timing matters. You want troughs, steady states, recent dosing changes. Remember, you're treating the patient, not the reference range. With respect to pharmacokinetics, you need to anticipate the risk before it happens, and you need to recognize when kinetics are linear and predictable and when they're not. Now, zero order saturation, enzyme induction, absorption limits, these patterns explain sudden toxicity or failure. Pharmacogenomics is using the phenotype, not the raw genotype, to guide your decisions. So you want to follow guidelines from CPIC when it matters, right? You want to know about the 2D6 and the C19 and the HLA, but never forget that genes modify risk. They don't make decisions for you. So the takeaway is simple. You need to integrate the labs, the kinetics, the genes through the lens of clinical reasoning. We would like to say we're moving away from trial and error prescribing and more towards evidence-based targeted care, not because we have more tests, but because we understand how to interpret them together. So here's as close as we're going to get. Precision psychiatry is not genetics alone. It's serum levels, pharmacokinetics, and genetics working in concert. So the level tells you what's happening. The pharmacokinetic tells you why it's happening, and the genetic tells you why this patient is different than the average. And the goal is simple. That is to treat the patient, not the population average. The population averages are how drugs get approved, but that individual variation is how patients actually respond. So the good news is you don't have to start with anything exotic. You can just start with the high yield basics, right? Lithium level timing, was it really a trough? Clozapine A and C, does this represent pathology or expected variation? CYP2D6 and 2C19, are we dealing with a poor metabolizer, ultra rapid metabolizer, or phenoconversion? These are low cost, high impact moves that are going to immediately improve the safety and efficacy. So, Clinical Pharmacogenetics Implementation Consortium. This is the gold standard for pharmacogenomic guidance. CPIC does not tell you when to order genetic tests. Instead, it answers the practical question, if I already have a patient's genetic result, how should that change my prescribing? The CPIC translates genotype, the raw genetic result, into phenotype, meaning predicted drug metabolism, and then into specific clinical actions like dose reduction, avoidance, or alternative selection. And the website is there for you to look at. Second, the FDA has pharmacogenomic labeling. The FDA, Food Drug Administration, maintains a resource called the Table of Pharmacogenomic Biomarkers in Drug Labeling. And this tells you which medications have genetic information embedded directly in the official drug label. And that matters for things like safety and documentation and medical legal protection. Not every drug has a CPIC guidance, but if it's in the FDA label, you should at least pause and ask why. So do a Control F on your PDF and search for the CYP 450 and see what it says. Third, you need to know your lab. Every health system has a reference lab that's slightly different ranges and protocols. So this matters for therapeutic drug monitoring, meaning those measured drug levels. So lithium levels need to be drawn at a 12-hour trough. Clozapine levels depend on timing, smoking status, inflammation. Valproate levels may look normal while ammonia is dangerously high. So precision care requires knowing which lab you use and what their reference range is and when the blood was actually drawn. Now, fourth, we have the American Psychiatric Association and the International Society for Bipolar Disorder. These organizations publish consensus guidelines for complex or high-risk cases, especially when evidence is mixed or evolving. Now, when pharmacogenomics, serum levels, and symptoms don't line up cleanly, these guidelines are to help you justify thoughtful, defensible decisions. Now, this is the most important part. Here is a practical takeaway. So this week, I want you to identify 2 to 3 patients in your current rotation or practice or that you've had and ask a single question. Would checking a drug level or a genetic variant change what I would do today? And if the answer is yes, then that's a high-yield use of therapeutic drug monitoring, pharmacokinetics, or genetics. And if the answer is no, don't order it. That's precision psychiatry. So these tools don't replace judgment, they sharpen it. So treat the patient in front of you, not the population average and not the lab value.